What I'll try and cover in this short presentation is a brief review of the properties of saliva, focusing particularly on the antibacterial, antimicrobial mode of action of some of the selected factors, but also how saliva can promote a balanced and healthy oral microbiome and the benefits of that more microbiome to our health and well-being, before summarizing and hoping this provides a platform for our subsequent speakers. Saliva forms a thin film over all oral surfaces, and in fact we produce about 1 litre of saliva a day. Many of you have travelled to this meeting by air and had to go through security, and I hope that the volume of saliva in your mouth wasn't a problem like occurred for this lady. The corollary is that when you're under stress, like giving a talk, all the saliva just vanishes miraculously. So saliva is mainly composed of water, and it contains a wide variety of proteins. And with the advent of modern proteomic techniques, several thousand proteins can now be detected in saliva. There are also glycoproteins that have important functions, as well as a range of inorganic molecules, lipids, and vitamins. Saliva is a major buffer for the mouth and keeps the mean pH around neutrality, which is beneficial for the growth of many oral bacteria. So saliva plays a fundamental role in maintaining oral health. It provides the lubrication and swallowing we need for the chewing, tasting, clearance of foods. It acts as that buffer, and it can also contribute to wound healing. It has important effects on the hard tissues, reducing demineralization and promoting remineralization, and has effects on the microorganisms. So it can prevent the colonization by certain groups of organisms through the production of glutenins, by the presence of components of the innate and adaptive host defenses, but it can also promote the growth of certain microorganisms. So it forms a conditioning film over the surfaces in the mouth, sometimes called the acquired pellicle, and this can promote biofilm formation through the presence of receptors, and it also is the main source of nutrients for the growth of our natural microbiota. On this slide are listed many of the factors that are present in saliva that have antimicrobial effects. It's not an exhaustive list, and it's meant just to show the wide diversity of molecules that are present. And they range from molecules that can aggregate microorganisms in solution in saliva, and this aids their clearance by swallowing, down to specific molecules that will lyse bacteria or have certain antimicrobial, antifungal, antiviral effects, and also can inhibit a range of enzymes. The important thing to stress is that these innate components are multifunctional with a high level of redundancy, which means that many of the molecules have more than one function, and many of the molecules have similar functions. So, for example, with the cystatins, they're antimicrobial and immunomodulatory, as is lactoferrin, and lactoferrin can also sequester iron and restrict microbial growth that way. The innate factors are supported by the adaptive host response, the main factor of which is secretory IgA, which prevents adherence of microorganisms in the mouth and can also inhibit enzymes. And other immunoglobulins can be present in saliva. The main one would be IgG, but also IgM and IgA. And something that should be stressed, although many of these factors have modest activity and can be present in low concentrations, they actually function synergistically. So many of the molecules I've mentioned can bind together, they can aggregate, and their effects are then additive or even synergistic. I'm now just going to say a few words about a few of the antimicrobial factors that will be relevant for other speakers in this talk. So one of the main antimicrobial factors in saliva is lysozyme. It's a small peptide, and is well known as an agent that can lyse peptidoglycan, which is the main structural component of bacterial cell walls. But it can also permeabilize bacterial membranes, and that can assist the penetration of other molecules into the cell. It can bind LPS, it also has some antiviral activity, and again can aggregate organisms, which reduces their ability to adhere, and it remains active in pellicle in the mouth. Lactoferrin also exists in an iron-free form, apolactoferrin. So this is a multifunctional protein, and its importance can be gauged by the fact that it's not only present in saliva, but also in a range of other bodily fluids, from tears, nasal secretions, and milk, and so on. So it's well known for its bacteriostatic function of binding iron, which is an essential cofactor for microbial growth. But it also has an iron-free activity where it is bactericidal. It can also have antiviral and antifungal activities. It's also anti-inflammatory, has some anti-cancer properties, again, immunomodulatory, and reduces biofilm formation. Salivary peroxidase system is an enzyme system that catalyzes the reduction of hydrogen peroxide and oxidation of thiocyanate to form hypothiocyanate. And the hydrogen peroxide for this reaction normally comes from oral bacteria in the mouth. So many of the beneficial streptococci produce hydrogen peroxide. The end product of this reaction is pH dependent. So at neutral pH, hypothiocyanate is produced, but at acidic pHs, it's hypothiocyanous acid. And these molecules can reduce bacterial adherence, but they can also damage bacterial membranes and inhibit important cellular activities. This includes glycolysis and the transport and uptake of sugars and amino acids, and a range of other enzyme activities. And this molecule or set of enzymes is also present in the salivary pellicle and retains activity when it is in the salivary pellicle. As I said earlier, there is a great deal of redundancy in the activity of these molecules, so it is often difficult to work out exactly their contribution to oral health. You can gauge some relevance from looking at genetic polymorphisms. So polymorphisms in the production of some of these defense factors has been linked with an increased risk of caries. And likewise, polymorphism in lactoferrin has been linked to traveller's diarrhea, another problem sometimes when you come to conferences. And lactoferrin with low iron binding capacity has been linked to some aggressive forms of periodontitis. More recently, a study has shown that low concentrations of host defense peptides such as LL37 has been also linked to an increased risk of caries. So it's often stressed about how these factors are antimicrobial in general, but as a professional microbiologist, I'm also keen on how some of these molecules can also support the growth of microbiota. So saliva plays an important role in maintaining a pH around neutrality, which is favorable for the growth of a large number of microorganisms. This is by its buffering activity and also by the clearance of substrates. And it promotes biofilm formation by the production of this conditioning film, which provides a number of receptors to which microorganisms can attach via their adhesins. Some of the receptors have been referred to as cryptotopes, and this means that when the molecule is in solution in saliva, they are hidden, but when the molecule binds to the surface and unwinds, then the receptors are exposed and organisms will be therefore able to attach to the surface. And many of these components that we find in saliva can be detected in the conditioning film, the acquired pellicle. And the important thing to stress is that these molecules, when they're present in the pellicle, retain their biological activity, including if they're an enzyme, their enzymic activity. Another major function of saliva is that they promote microbial growth. It consists of peptides, glycoproteins, amino acids, and so on. And the importance of these molecules to the growth of our natural microbiota can be gauged by the fact that patients who are fed by stomach tube still retain a diverse microbiota. So the microorganisms in the mouth are able to grow and survive by breaking down the glycoproteins, such as the mucins. But these molecules are structurally complex, and their breakdown requires the concerted and sequential activity of often multiple organisms working collectively to break them down. And this collective dependency provides stability and resilience to change of the oral microbiota. So here we have a schematic of a glycoprotein where we have a protein backbone decorated with side chains of sugars. In general, no one organism possesses all of the enzymes capable of breaking down these molecules. So organisms have to pool their resources in order to break these molecules down. So one organism may be providing a glycosidase that takes off the terminal sugar that is then exposing the next sugar in line that is the key substrate for a second organism. So these interdependencies mean that all organisms have a self-reliance on one another, and it generates very stable communities of bacteria. So what we have then with saliva is this generates a balanced oral microbiome, where on the one hand we have antimicrobial activity, but on the other hand we have saliva providing receptors for attachment and nutrients for growth. And this generally leads to a lovely symbiotic relationship between us and our microorganisms. And the benefits of these organisms are initially the exclusion of pathogens. So colonization resistance is a key factor of our natural microbiota. And if people are on broad-spectrum antibiotics, then you can get all sorts of problems, including overgrowth by Candida. The host, the oral microbiome also regulates the cardiovascular system through the metabolism of dietary nitrate. They're essential for the normal development of our host defenses, and the organisms themselves are engaged in crosstalk with the host to ensure that they have an immunomodulatory role in keeping a balance with the host. And these organisms also provide additional metabolic capabilities. So in summary, saliva plays an essential role in maintaining our oral health. It contains numerous multifunctional molecules, many of which are antimicrobial, and they act together synergistically. But it also has properties and functions that promote a natural and diverse oral microbiome, and that has a synergistic relationship with the host that delivers important benefits and promotes our oral health and well-being. And therefore, enhancing the levels of some of these natural antimicrobial factors in saliva is a plausible approach to promoting oral health and reducing future risk of disease. And with that, I'd just like to acknowledge colleagues that have worked with me in my base at Salisbury and also at Leeds for their help and contributions over the years. Thank you very much.
So today I'm going to talk about insights into the microbiological benefits of using a toothpaste with natural enzymes and proteins. I'm going to briefly touch on the role of saliva in health and the importance of a balanced oral microbiome, how we can enhance our natural salivary defense factors using a toothpaste containing natural enzymes and proteins, the results of some in vitro microbiology study, and a clinical study to look at the effect of an enzyme with toothpaste with enzymes and proteins on the plaque microbiome. So, Professor Marsh has very eloquently explained the importance of a balanced oral microbiome. It is essential to our health, be it cardiovascular or gut or even the mouth. However, this can be perturbed by many factors such as diet, stress, poor lifestyle, poor oral hygiene. However, in the mouth, saliva helps to maintain a naturally balanced oral microbiome. And as Professor Marsh has explained, saliva is a complex network, a synergistic system working together, enzymes, proteins, lipids, many cofactors that have antiviral, antifungal, and antimicrobial properties that help to maintain that balanced oral microbiome. So the question is, how can we boost that? Can we augment our saliva defences? So Zendium is a daily toothpaste that works with those mouth's natural defensive systems to promote all-round health through balancing the oral microbiome. So I'm going to very briefly introduce you to Zendium and its components for those that are not familiar with it. So firstly, Zendium contains an enzyme cascade system. So we have 3 enzymes that produce hydrogen peroxide, which is a natural antimicrobial, which is found in the mouth, not only derived from microorganisms, but also from host defences. And it also produces hypothiocyanate, again, a natural antimicrobial present in the mouth. So we have AMG, which is an amylase, which produces glucose from polyglucans present in your mouth. That then is taken by glucose oxidase to produce hydrogen peroxide. And in turn, lactoperoxidase produces hypothiocyanate. So that's an enzyme cascade through hydrogen peroxide and hypothiocyanate. Zendium also contains 3 natural proteins. So these are lysozyme, and as its name suggests, and Professor Marsh has already explained to us, as well as lysing cell walls, has many other properties, and lactoferrin, which as well as binding iron, in itself prevents cell-to-cell adhesion and also can lyse cell walls because it has cationic functionality. And finally, we have colostrum as a source of immunoglobulin. And as Professor Marsh has discussed, these enzymes and proteins work together. So there is a synergy between the enzymes and proteins, and this mimics what happens naturally in the salivary defense systems in your mouth. So I'm going to move on to say, how does Zendium boost those natural saliva defenses that are present in your mouth, and how did we measure this? So firstly, this is an in vivo delivery study. So in this study, we compared the concentration of some of the defense factors after brushing with Zendium compared to a controlled toothpaste that did not have enzymes and proteins. It was a double-blind randomized study with 46 subjects of a mean age of 39. We asked subjects to brush for a minute with either a Zendium toothpaste containing enzymes and proteins or a controlled toothpaste without enzymes and proteins, and saliva samples were taken. We then analysed the saliva samples for hydrogen peroxide using the Pierce xylanol orange assay and lysozyme activity, again using a commercial NCHEX assay. And we carried out statistical analysis. So in summary, we saw that after brushing with the Zendium product containing enzymes and proteins, we saw boosted levels of hydrogen peroxide present in saliva compared to the comparator toothpaste, and these levels were 64% higher. And likewise for Zendium activity, this was also raised following brushing with the Zendium toothpaste compared with the comparator. And I would also ask those of you who have time this afternoon to maybe go around the poster session and look at a poster by Richard Skinner and his co-workers where he has looked at the deposition and retention of these enzymes and proteins within the pellicle. So, we've boosted the host defense factors. What impact does that have on the microbiology? So first I'm going to turn to an in vitro study. And here we have looked at the effect of Zendium on a complex multi-species biofilm. So I'll maybe take a few minutes to explain to you what this model is. So it's a constant depth film fermenter model. It's sometimes called a CDFF model for those that are microbiologists. So in this model, we grow saliva-derived biofilms into little recessed pans, and in the bottom of those pans, you place a piece of bovine enamel, so you're growing a biofilm derived from saliva on an enamel surface. You maintain that biofilm by having a scraper that goes around the biofilm, so that mimics what happens in the mouth because you brush and you have your tongue and you have saliva flow. You can flow through media and nutrients, so again, you're mimicking what's happening in the mouth. You can flow through glucose and sucrose challenges to mimic eating and drinking. And in this study, we actually looked at Zendium toothpaste and a matched control that did not contain enzymes and proteins, growing biofilms over 4 days. And the biofilms were taken out periodically, and we did bacterial counts, either using non-specific or selective agar. So, as well as seeing reductions in the total counts of the bacteria grown on those enamel disc over the 4 days, I've highlighted one piece of data here, which is specifically the growth of S mutans, and you can see from day 1 through to day 4, we see significantly reduced numbers of strep mutans within those biofilms. So not only does the Zendium with enzymes and proteins reduce the overall biofilm growth from as early as day 1, but we also see that it's reducing the incidence of strep mutans, which is important because clearly everyone here knows that's one of the bacteria associated with caries. So that was in vitro. What about the clinical situation in the mouth? So I'm going to briefly introduce a clinical study in which we looked at the impact of Zendium on the microbiome. So the objective of this study was to determine the effect of Zendium toothpaste on the plaque microbiome profile over a period of 14 weeks compared to a fluoride control product that did not contain enzymes and proteins. We had 111 healthy volunteers with a mean age of 42. There was a 4-week lead-in period, followed by a 14-week test period, where subjects brushed twice a day at home with the allocated toothpaste. And we collected plaque samples at the baseline, so at the beginning of the 14-week period and at the end of the 14-week period. And plaque samples were processed using a 16S rRNA gene amplicon sequencing method. So I'm not going to go through this slide, it's got lots on it in much detail, but just to give you an overview of our microbiome processing pipeline. So we collected the clinical samples, they were amplified, they were sequenced by our partners at the Centre for Genomic Research in Liverpool University on an Illumina MySeq. We then used a bespoke bioinformatics pipeline, and the samples were then processed through the Forsyth Institute's pipeline to obtain species-level identification. And we carried out statistical analysis both at the overall community level and down to the species level. And for those that are interested, there is a lot more information on this in Adams et al., which was published in Scientific Reports in February last year, and it's an online free access. So, firstly, to the community level analysis. We used beta diversity to understand the differences between the communities across each of the time points, and significant differences between the communities were assessed by using ANOVA. So what we found was at the beginning of the study, the two groups, there were no differences in their overall microbiome in the plaque. So the control group and the test group, the Zendium with the enzymes and proteins, did not differ at the start of the study. At the end of 14 weeks, we found that the Zendium had shifted the plaque microbiome, and it was now significantly different from the baseline. This is in contrast to the control product, where we did not see any difference at the end of the 14 weeks. So there was a shift in the plaque community for Zendium, there was none for the control product. So I'll just explain these charts. So these are ordination charts. They're simply a means to take masses and masses of complex data and show it in a simple way. So each of the small dots is one plaque microbiome sample. So they might be quite hard to see at the back, but there are tiny dots. The larger spheres are the 95% confidence intervals of the shared microbiome for each time point and product. So you can see on the left-hand side here, the spheres overlap. So that tells you there was no significant change between the baseline and 14 weeks. For Zendium, the spheres are apart. That is an illustration of how there was a shift in the plaque microbiome for Zendium over the 14 weeks. Then we drill down to species level. So I'm showing here the resultant taxa, and we looked at the changes in taxa, and we went to the literature and we looked at were the changes in the species and the taxa we saw associated with either gum health or gum disease. So for Zendium, we found that 37 taxa significantly changed throughout that 14-week period. 18 taxa significantly increased in relative abundance, and of those, 12 were positively associated with gum health. So they were in particular Neisseria species and streps of the Mitis group. Then we also found for Zendium that 19 taxa had significantly decreased over that 14-week period, and of those, 10 were associated with gum disease. And in particular, there were a number of spirochetes in the Treponema family and also Prevotella intermedia. You can do the same, we did the same for the control product. In this case, we saw fewer changes. Only 17 taxa significantly changed in abundance over that 14-week period. Here, 7 taxa significantly increased in relative abundance. Only 1 was associated with gum health, and that was the same Mitis streptococci we found in the Zendium group. 10 taxa significantly decreased in relative abundance, and 4 of these taxa were associated with gum disease, including Prevotella oralis. So, in conclusion, a toothpaste containing enzymes and proteins can modulate the oral microbiome, resulting in a community with a stronger association to gingival health. These results strengthen the evidence that use of toothpaste which augment and boost your saliva defense factors is relevant to promoting gingival health. And finally, we need to remember that oral health is promoted by product choice together with good twice-daily brushing habits and appropriate diet and lifestyle choices. I would have to acknowledge many of my colleagues and fellow collaborators who are here and today. So finally, to thank my colleagues in Port Sunlight and in Casale in Italy, my professional and scientific affairs colleagues, Professor Marsh, Dr. Chen at the Forsyth Institute, and Professor Hyam at the University of Liverpool. Thank you for your help in these pieces of work.
Thank you to Unilever Oral Care for giving me the opportunity to present the results from a clinical study on the effects of using toothpaste with natural enzymes and proteins on the gingival health. I must stress that Unilever Oral Care UK has sponsored the study and supported it together with the University of Copenhagen. In Denmark, we have had the opportunity to use Zendium toothpaste for about 40 years. It has been available on the market. And we were really interested in to see, are there any beneficial effects of adding these kind of natural enzymes and proteins that you already heard about into a toothpaste? Can we actually see any beneficial effects of long-term use of this toothpaste? And the objective was therefore to examine the relationship between the long-term use, and here we say more than 1 year, of a toothpaste containing these natural enzymes and proteins, and gingival health, and this is in terms of gingival inflammation, plaque levels, and gingival bleeding, compared to those who had a long-term use of a toothpaste without these ingredients. It was a single blind with respect to the clinician. The clinician wasn't blind, obviously, but it was blinded so that the clinician who investigated or recruited the patient didn't know what type of toothpaste the participant used. And it's a cross-sectional study. There were 2 visits at the study site, at the clinic at the School of Dentistry in Copenhagen. The purpose of the visit 1 was the screening and the medical history, and to obtain informed consent and obviously enroll the participant. Visit 2 was a clinical examination, including assessment of gingival health. And there were different persons screening the patient and another person doing the clinical examination. The test group must have had a continuous use of Zendium toothpaste for at least previous 12 months, and the control group must not have used Zendium triclosan or zinc citrate containing toothpaste for the previous 12 months, but have used any other types of toothpaste for the previous 12 months. And the participant was then allocated into subgroups according to gender and age. We had quite many exclusion criteria. One of them was diabetes, both type 1 and 2, actually known to affect the gingiva and associated with periodontal disease. Full and partial dentures, use of mouth rinses within 4 weeks of the screening appointment, oral piercings, ongoing orthodontic treatment, inflammatory systemic diseases, and current antibiotic treatment within 4 weeks of the screening appointment. As this study was a part of another larger study, including other aspects of oral health, the study participant was asked not to consume spicy foods or alcohol for 24 hours prior to the visits. And we were very keen on this one, and this was a difficult inclusion criteria. And they were asked not to brush their teeth from 11 p.m. on the evening before visit 2. They were asked not to eat and drink 2 hours before the visit 2, and they were asked to refrain from use of mouthwash or change of toothpaste used as a part of normal hygiene. And they must not have had routine dental treatment for the duration of the study, including scaling and polishing. We used these, for you, maybe well-known methods to assess the gingival condition. Of course, you also looked at the oral mucosa as a whole. For the gingival condition, we used the modified gingival index, the plaque index, and the bleeding index, and they were also interviewed regarding general and oral health, presence of systemic diseases, oral diseases, medication intake of food supplements, and any allergies. They were also asked about their routine dental hygiene habits, dietary habits, alcohol and tobacco consumption, and other potential confounding factors. The assessment of gingival inflammation was graduated from 0 to 4, where 4 is very severe inflammation, marked redness, and edema and hypertrophy of the marginal or papillary units, as you can see on this picture. For the assessment of plaque levels, each tooth surface was divided into 3 equal areas where we assess the level of plaque from 0 to 5, and you can here see the various degrees of plaque being present. And then we assessed the gingival bleeding by using a probe and scored from 0, no bleeding, to the most severe one, spontaneous bleeding, as you can see here on the picture. Quite a lot of people were pre-screened by an interview performed by Gallup TNS. It's a research market company in Denmark who phoned people, and they've called about more than 10,000 people and asked them to participate and whether they were eligible to be included in the study. This resulted in an exclusion of more than 10,000, about 10,000 people. Another went for the screening visits, about 531 people. So they were scheduled for the screening, and some just didn't show up, and some did not fulfill the inclusion criteria. So at the end, clinical examination, 341 was actually scheduled for the clinical examination. Hereof, about 36 had no-shows or we had an error due to data recording in 2 persons. So at the end, the post-examination questionnaire was performed in 305 persons. They were distributed into 2 groups according to their gender and age, and you can see the distribution here. We initially want to have a specific number in each group, and we almost performed that by the screening. So it worked quite well. Now for the results. What we may not have anticipated to see was that there was actually a significant difference in the level of gingival inflammation. So those who had been using Zendium for more than a year, they had actually lower levels of inflammation compared to those who had used another toothpaste. Similarly, we found that the plaque levels were lower in the Zendium users compared to the users of other toothpastes. And also, regarding the bleeding index, the bleeding levels, the gingival bleeding was lower than in the control group. Looking at the gender, we was not quite surprised to see that the women had significantly lower levels of gingival inflammation, lower plaque levels, lower levels of gingival bleeding. It's well known from a number of studies that women have a better gingival health than men. Regarding the age, we were not that quite surprised to see that the youngest age group from 18 to 30 years had higher levels of gingival inflammation and higher levels of gingival bleeding, because they usually occupied with various other social things and might have a period of neglect for oral hygiene. When they have lower level of plaque, it may be explained that now they were going to this examination and they actually brushed their teeth, so that might be explained by that factor. So not pretty much surprised here. And obviously there are a lot of confounding factors in these kind of studies, and we of course did statistical analysis on various of these confounding factors, and we found no difference regarding the overall general health, intake of medication, alcohol and tobacco habits, dietary habits, oral hygiene practices, and dental attendance. To conclude, the findings from this study, this clinical study, indicate that long-term use of toothpaste containing enzymes and proteins that are naturally present in saliva is associated with a better gingival health than the use of other types of toothpaste. The data and the results were actually confirmed later by this study you already heard about by Adams et al., which has been published and showing a beneficial shift in the oral microbiota that could be an explanatory factor in explaining this beneficial effect on the gingival health. I would like to acknowledge my colleagues in Copenhagen, Associate Professor Daniel Bellstrom, who was the study coordinator, dental hygienist Marita Darwish, who performed the clinical assessment, the dental student for their valuable assistance during the study, and all who had assisted at the Department of Odontology. And also thank you to Unilever Oral Care for supporting the study.
Now we all think we can brush our teeth, and we all think we're reasonably good at it. But in reality, many of us aren't too good, and some of us are really appalling. And if we don't disrupt the biofilm on a regular basis, it becomes dysbiotic, and we get the emergence of pathogenic strains that can lead to gingivitis or perimucositis in the type of implants. And we've heard about the importance of the microbiome in health and preventing disease. The degree of microbiofilm accumulation that's relevant from the point of view of developing periodontitis depends on the risk factors and risk profile of our patients. If we're not susceptible, we develop gingivitis, which is self-resolving. However, if we have risk factors, genetic factors, and epigenetic factors, this can trigger a destructive response that's exaggerated, and we can end up losing bone in our teeth. Now, we know if we look at European adolescents that about 100% of them have gingivitis. The first thing they do when they get up in the morning, or if it's like my children in the afternoon, is reach for their phone before they reach for their toothbrush. We know adults are better due to education, but generally, worldwide, gingivitis is still a problem. And we know this can progress to our periodontitis, which affects 50% of the population, with severe forms 11%, and it's the 6th most prevalent disease of mankind. So we really do need to act early and prevent gingivitis. We also know that there are links to systemic diseases, good associations with diabetes and cardiovascular diseases, adverse outcomes in pregnancy, and new emerging evidence with, for example, rheumatoid arthritis or dementia. So we need to help our oral healthcare professionals to instigate treatment at an early stage when we first see gingivitis or BPE1. Now, current solutions, we have, of course, our best form is toothbrushing, mechanical toothbrushing to prevent gingivitis. However, we've seen that most people really aren't that good at it. And if we ask them to brush again, they'll miss the same areas and have the same problems because they're creatures of habit. And we have adjunctive agents which can help and have good efficacy. Toothpaste, I've listed here good adjunctive agents, and of course we have mouth rinses. And ideally, toothpaste would be the best because we use those on a daily basis. But ingredients in both toothpaste and mouth rinses can have side effects. And there's always room in the marketplace for a gentler type of adjunctive agent. We conducted a randomized controlled study to measure the effectiveness of mechanical and chemical plaque control with Zendium toothpaste compared to a fluoride conventional toothpaste. You've heard about Zendium this morning and how it works with naturally occurring enzymes and other proteins. And it's designed to tip the balance into health and contains a different type of surfactant to most toothpastes, the stearat 30 instead of the SLS. Our study design was a double-blind, randomized, parallel, 3-month at-home use study in healthy volunteers. Volunteers need to be over 18, have an MGI score of between 2 and 2.75, and at least 20 natural teeth. Subjects were given an oral prophylaxis, issued with a fluoride toothpaste and brush, asked to brush twice a day, and returned for baseline visits a month later. And we aim to recruit a minimum of 240 subjects. Our gingival index was the Labini, and I won't go through that here. A very well-recognized scoring system, 4 sites the tooth on a 5-point scale. Our examiner was trained and calibrated before the study. Our exclusion criteria: pregnancy, medication that might affect the gingivae, periodontal disease, orthodontic appliances, smoking, oral piercings, and employee of the site. At baseline, we looked at ongoing eligibility, and all MGI scores had to be less than 3. Our participants were then randomised using a gender stratification to one of the two products for twice daily brushing for the duration of the study. Subjects were not allowed to brush their teeth or use an oral hygiene project that wasn't given to them as part of the study, and they could not brush their teeth after midnight the visit before their next scoring session. They also couldn't eat and drink for 1 hour before their next appointment. And our treatments, we had our control, which was a standard fluoride paste but with no SLS, and our test was our Zendium toothpaste. If we look now at 13 weeks, 3 months later, we did a modified gingival index, our Labini again, our bleeding index, Saxton and van der Oudere, and our plaque index, modified Quigley and Hind. And we looked at intergroup differences, which are of course the most important, but we also looked for interested intragroup differences as well. Our bleeding index was this one, for those not aware of the scoring system, 3-point scale, 4 sites a tooth, and our plaque index, 6 sites on a 5-point scale. So if we look at the flow of the study now, 261 participants were enrolled in the study, and in the control group we had 116, and in the active we had 113. If we look now at the intra-group differences, you can see for MGI, BI and plaque score that the Zendium product was significantly better than our conventional fluoride toothpaste. And I've shown that graphically for MGI there. Intra-group analysis was also carried out for interest, and you can see that over the course of the study, for the Zendium product, the MGI and the BI and the plaque index improved, and for the fluoride paste, it generally worsened for those 3 indices throughout the study. In conclusion, brushing with the Zendium toothpaste demonstrated significantly better results for gingivitis scores, bleeding scores and plaque scores compared with the fluoride toothpaste. And brushing with Zendium has a clinically adjunctive improvement on gingival health compared with brushing alone again with that standard fluoride toothpaste. I'd like to thank Unilever for sponsoring our study, but most of all, I'd like to thank our clinical trials unit, many of whom are sitting here today, for conducting the study, and of course our clinician, Sinead Daly, for their help. Thank you.
Well, again, thanks to my colleagues in particular and to Unilever. This is, if you like, perhaps slightly left field as a study. This was a study that really was looking at the SLS-free nature of Zendium as a toothpaste versus an SLS-containing toothpaste. And I ought to state up front, before people start to get slightly twitchy here, that SLS has some fantastic properties. It's an important surfactant. It's an anionic surfactant, as you know, and many patients like it. It feels good, it foams, etc., etc. So this was really looking at effects on epithelial integrity and whether an alternative surfactant within Zendium is gentler on the tissues. So the background to this, the oral mucosa really is quite heterogeneic in terms of its microanatomical structure and its function. And some work quite some time ago by Chris Squire looked at this and really demonstrated that the greater the keratinization, the less the permeability of the oral mucosa. And here's a comparator with skin, if this laser pointer will reach. And you can see that as we go from skin to palatal mucosa to buccal mucosa, etc., the keratinization decreases, and as a consequence, permeability increases. And you'll be familiar with the floor of the mouth being used for drug delivery in certain situations for exactly that reason. There are a number of factors that will affect epithelial permeability. and keratinization, and inflammation is probably one of the most important. So it's well recognized that the more inflammation you have, the less keratinization and the more permeable the mucosa is. And other factors that can impact upon permeability would include trauma, certain chemicals, smoking and alcohol. And it's also been reported reasonably widely that SLS can in fact produce some alterations on the mucosa which may increase permeability and reduce sloughing. Sorry, increase sloughing. So experimental studies using SLS toothpastes have demonstrated epithelial desquamation and also a disruption to barrier function. And the SLS-containing toothpastes also appear to exacerbate conditions in people who perhaps have some kind of oral mucosal predisposition, such as aphthous ulceration, vesicular bullous diseases, etc. So again, just to make the point that SLS doesn't appear to have major issues with people with healthy oral mucosa, but it can cause irritation in those that are predisposed to oral mucosal conditions. And so the surfactant system within Zendium, the Stereth 30 system, which is not anionic, it's relatively neutral, was hypothesized to reduce or minimize physiological disruption at such biological interfaces. So the aims of the current study were to essentially evaluate the sloughing that was generated by a non-SLS containing toothpaste versus Stereth 30 within Zendium, and I shall use these terms interchangeably in the slides that follow in the results, compared to a standard SLS containing toothpaste. And the time points were taken as 30 minutes following application and then 4 days following application. And in order to do that, we developed a new mucosal sloughing index in order to quantify the sloughing. So this was a single center, double-blind study with a crossover design. So half the volunteers started on paste A, and then they crossed over to paste B, and there was obviously a washout and a wash-in period. There were 60 volunteers essentially recruited, 30 in each arm before the crossover, and clinical assessment of the oral mucosa was performed pre-application of paste, 30 minutes following the application of the pastes, and then 4 days later. It was a supervised protocol, so the pastes were applied to the maxilla in a cap splint, a regular mouth guard, so that was an acute application, if you like, for 2 minutes. And then the volunteers brushed for 2 minutes with the paste. So the mandibular arch was essentially treated as you would do normally with regular brushing. So you've got an acute application, and then you've got if you like, an application that's perhaps more clinically relevant to day-to-day practice. The index was relatively straightforward. There are some indices out there, and these were essentially looked at, and then using experience from the oral medicine field, a scale of 0 to 5 was developed with objective outcomes, 0 being no evidence of change, 1 being flecks of sloughing or desquamation, 2 being sheets of desquamation, and hopefully I can show you examples. So this would be flecks of desquamation. This would be a score 2, an intensity score 2, which is sheets of desquamation. Score 3 is where you have redness verging on erosions, but not quite, that's not plaque related. And a score of 4 would be frank erosions of the mucosa without ulceration, so the connective tissues are still just covered by a thin layer of epithelium. And then finally, a score of 5 would be frank ulceration. So it was a visual scoring system. The mouth was divided into 12 assessment areas. The tongue was counted as 2 surfaces, dorsal and ventral. The mouth was divided into the floor of the mouth and the roof of the mouth, providing a further 2 surfaces. The gingivae were divided into sextants, as we are all very familiar with. Therefore, we had 6 sextants. So 1 sextant, you would count both buccal and palatal or lingual surfaces within that score. And then the cheeks, we tend to have 2 of those, so they counted as 2. So we have 12 surfaces in terms of the total number of surfaces that were assessed. This is a flow chart, so this is group 1, and what it essentially shows you is a wash-in period with an SLS paste, a non-SLS containing paste for a 10-day period. And then the volunteers were assessed at baseline. The paste A or B, depending upon which arm, was then applied, and there was a 30-minute check for sloughing after the application. There was then, the subjects used the paste, and they were seen 4 days later for a final assessment. And I should point out that when they came in for that final assessment 4 days later, it was several hours after they'd used the pastes before they were being assessed. So this wasn't an immediate 30-minute or 1 hour assessment following use. There was then a wash out and a wash in period with the non-SLS paste, and then they were again seen for a baseline assessment, the application of the second paste, and then the 30-minute check, and then the final 4-day check. And the other group essentially had exactly the same, but simply in reverse. So in terms of population, that shows you the demographics. There were 29 volunteers that completed against a power calculation of 25. We had data available for 28 volunteers for the test toothpaste containing the Stereo 30, the Zendium paste, and we had 29 volunteers for the toothpaste containing SLS. I think what's important here is there were no dropouts due to use of any of these pastes at all. So in terms of outcomes, the whole mouth lesion count per volunteer, each severity score above 0 was essentially treated as one single lesion. So this is not intensity related, it's just in terms of total numbers of lesions across those different assessment areas with a maximum score of 12. So the individual area datas were calculated as I've explained. So we had a maximum score of 6 for the gingivae, 3 in the maxillary gingivae, 3 in the mandibular gingivae, 2 for buccal mucosa, a maximum score, and then floor of mouth and roof of mouth 2, and tongue, dorsal and ventral 2, providing the 12. And then we also looked at a subject level at mean mucosal severity sloughing per 12 sites. This is quite a data-heavy slide, so I'll take you through it slowly. What this basically shows you is, and this is not paste-specific, this is overall for the population, it shows you the intensity score 0 at each time point pre, post 30 minutes, and post 4 days. And you will see that at baseline, the majority were absolutely unremarkable with no evidence of any lesions at baseline. And then we have a fall in the number of healthy sites at post 30 minutes, and then we have a slight recovery at 4 days. If we look at intensity score 1, then you can see we have fewer intensity score 1s because they're all in the 0 category, but then we have a significant increase across the whole study at the post 30-minute period, and then a recovery at 4 days. And the pattern is very similar for score 2, but we obviously have fewer of these lesions as you would expect. And the pattern is then similar for score 3, but again, very few of these lesions, which is reassuring because toothpaste generally don't cause erosions or redness. And then a similar pattern for erosions. We had no score 5s, no frank ulceration, which is why I've not shown it here. Then when we look at the lesion count distribution against the different time points, what you can see here is post 30 minutes, post 4 days, and this would be the number of volunteers in both the Zendium group and the SLS group that had between 0 and 2 lesions. And so you can see that at baseline, there were 25 in the SLS group, 24, no difference between the two groups. And then when we get to the post 30 minutes, we have more health to very, very early flecking in the Zendium group versus the SLS group. When we get to the 3 to 5 level, then that situation reverses. We have significantly more in the SLS group than we do in the Zendium group. And then when we get to 5 lesions or more, more than 5 lesions, then we have, again, at 30 minutes more in the, significantly more in the SLS group and none in the Zendium group. And I've just highlighted the key differences here, and we'll have a look at the statistics in a moment. So the overall mouth lesion count, if you like, adding that lot together, gives a very straightforward picture. No difference at baseline between the two pastes. Then at 30 minutes we have a statistically significantly higher number of lesions in the SLS group than in the Zendium group. And then after 4 days, there's again no difference between the groups. When we look at the lesion count per site, we start with the lower gingivae, then the upper gingivae, the roof of the mouth, the tongue, dorsal surface and tongue ventral surface. Again, you can see here that if we look at 30 minutes, and I've highlighted the differences here, there were higher lesion counts in the SLS group than there were in the Zendium group. And statistically, and I think this is important in terms of the validity of the model that was used, remember we had an acute application in the upper gingivae, and there was statistically more lesions, as you would expect, I guess, in the SLS group than the Zendium group. And we also found that in the lower gingivae, just with a regular 2-minute brushing application in the non-acute application. So the acute application and the non-acute didn't appear to produce a difference in outcomes. In terms of the average severity score, so the average severity score is shown here, and if we look post 30 minutes, there was a significant difference with a greater severity in the SLS group than in the Zendium group, and at 4 days there was no difference between the two groups. So to summarize, essentially the mucosal sloughing index is a new tool that we've had a look at, and that appears to enable a systematic recording of lesions across the mouth. We observed significantly fewer lesions at 30 minutes post-application in the Stereth group, the Zendium group that is, versus the SLS group, on the basis essentially of whole mouth lesion counts, but also site-specifically for upper and lower gingivae. After 4 days of use, there were no significant differences between the products. The majority of lesions were gingival lesions and palatal mucosal lesions. And of the 4 lesions that had an intensity score of 3 at 4 days, then 3 were in the SLS group and 1 in the Zendium group. And of the 3 lesions that had intensity score 4, these are rare, obviously, 2 were in the SLS group and 1 in the Zendium group. And so the observations in this study using this new index with respect to the products did appear to be consistent with prior literature. So to conclude, mucosal disruption and desquamation may adversely affect barrier function of the oral epithelium and lead to adverse effects, including discomfort, ulceration in some individuals, and potentially can be associated with bacterial entry into connective tissues. Certain chemical agents in toothpastes, such as SLS, are reported to cause epithelial sloughing in certain people who are susceptible. And this new mucosal sloughing index does appear to be effective in identifying both severity and extent of epithelial disruption. And then finally, in this study, the Stereth 30 surfactant system was associated with less epithelial disruption than the SLS paste. And so it may actually be gentler on the oral epithelium in those susceptible individuals. And I'd like to just conclude by recognizing my colleagues who did all the hard work, and thank you for your attention.